Good morning, everyone. I would like, first of all, to thank Leonard and James for their leadership and for allocating a full day to this topic, because we know how important it is. I would second like to thank the members of the Planning Committee, whose names you see behind me. I can personally attest to the fact that this Planning Committee kept the lived experience of patients and families at the center of all of our planning discussions, and I hope that that will show as we walk through the day today. Third, I would like to give a huge thank you to Lori Gregg and Caitlin Friedman and their colleagues at the National Academies, who made a lot of cat herding and excellent facilitation look easy and pulled it off into a seamless workshop today. And finally, I'd like to thank all of you for being here today and those of you who are joining in on the webcast. Our topic today is workforce, and as James said, this is really where the rubber meets the road for patients. And although I don't think that patients would often name workforce as a source of suffering, nor should they have to, this is where we see a lot of the systems and the policy that we talk a lot about in our field come into play in patient interactions and patient care. And during the planning of this workshop, I had two personal opportunities to reflect on the importance of this topic. The first was that my grandmother was diagnosed with brain cancer. And in the hospital where she was receiving care, I talked to the leader of a very small palliative care program that they had at the hospital. And she told me that she had budget to recruit more providers to her team, but that she couldn't because there is such a workforce shortage and she was not in a region where she could attract palliative care professionals. And so she freely admitted that her team was not able to see all of the patients who could have benefited from her care. Several weeks later, my great aunt fell ill very suddenly and died in the hospital. And as she was receiving care in the intensive care unit, I asked her team if we could organize a family meeting to talk about what would have been important to Marilyn. And I could see the anxiety and hear it in the voices of her team, not because they did not care about my aunt, Marilyn, or because they didn't think that having that conversation was important, but because they did not know how to approach it. And so I could see that they had not had training in the skills needed to have a discussion with my aunt about what really mattered to her. And it made it really difficult for her and for our family, and I think for her clinical team, to navigate decision-making during her last week of life. So this is really important for our patients. Our committee, workforce is one word with a lot of components and a lot of stakeholders, and our committee wrestled with pulling that to the ground and separating it into its component parts. And there are two topics that we will not be discussing or making a primary focus today, and I want to acknowledge them. The first is payment. I think we would all agree that without adequate and appropriate payment mechanisms, we cannot staff the interprofessional teams that are appropriate for our patient population. But because that is such a giant topic and the focus of another workshop, it won't be our primary focus today. The second is family and other unpaid caregivers. We absolutely recognize what a critical component of the care team and a huge by volume percentage of the de facto workforce for patients with serious illness that caregivers are in this country. But again, because of the enormity of that issue, and because it is the topic of a dedicated workshop, it's not a primary area of focus today. So what we will be talking about and what is in scope today is first, the specialty workforce, the workforce of clinicians who are specializing in the care of serious illness, what the trajectory and the pipeline for that workforce looks like. So that when my grandmother was in the hospital, she would have had a team that had more capacity to care for her and her fellow patients. The second topic that we'll talk about today is the rest of the clinical workforce not working in palliative care, and the skills that would benefit their patients with serious illness that many practicing clinicians or graduating clinicians have not been trained in. The third topic on the agenda today is care in the community with a focus on the home health workforce, who are a huge percentage of the touch points that our patients have with the health system when they're living in community, and with an examination of what the real lives of patients look like in all of their beautiful messiness and how we need to accommodate that in the care we provide in the community. And then finally, in our fourth panel, we will take a look at how all of these pieces come together, how we can rally and integrate the specialty and non-specialty workforces to serve the needs of our patients wherever they're receiving care. And we have several innovative programs and organizations who will be showing how they've managed to pull this off now, despite the challenges. A final word from me before I hand it over to my co-chair, Brenda. In October of last year, the National Consensus Project published a fourth edition of their clinical practice guidelines for quality palliative care. Now, the NCP guidelines define what quality palliative care service delivery looks like and how it's made up. The fourth edition was published last year not because the people involved had nothing better to do, but because the NCP guidelines really needed to evolve to reflect shifts in the healthcare system that impact our patient population. First, that meant very explicitly outlining palliative care delivery with quality in community care settings and illustrating with examples of how this can be done well. Second was acknowledgement that in not every care setting is there, or sometimes should there be, a specialty palliative care team. And so the fourth edition of the NCP guidelines outline how non-specialty programs and practices can adhere to the NCP guidelines for quality in their care of seriously ill patients with the teams that are providing care today. So I would ask you to pay attention to these two themes in the presentations that you hear today, and we'll be coming back to them from time to time. Brenda.